Yeah, we can see your screen which says share device audio and optimize video.
Perfect. Now, can you see my screen?
Yeah.
Can see
So
it,
this
yes.
is the start of the presentation. Yeah.
Yeah. So Aditya, you'll have to just tell me when to move forward. I'll start. Yeah.
Yes.
Yeah. You can introduce yourself and start. Yeah.
Yes. Good evening, everyone. I am Dr. Aditya Kashikar. I am consultant spine surgeon working with VR Spine team for last many years. So to start with this fellowship program, today we are going to discuss about prolapse intervertebral disc in lumbar region. So we'll start with our presentation. Harshal. So in our clinical scenario, we come across many patients who come to us with low back pain with this kind of MRI picture. Next. So we see these kind of black disc or prolapse disc with stenosis. Next. So they often ask us about what is this and what will happen to that, or why this has happened, and what will be the fate or prognosis of this condition. Next. So when these all questions are bombarded at you, so as a clinician also, depending on the clinical and MRI picture, you are also in a dilemma whether to go ahead with conservative treatment or operative treatment. Next. So in next 19 minutes, I'll be talking about the normal and altered physiology of the disc, which leads to disc prolapse and the treatment modalities for that. Next. So we'll start with normal anatomy. We'll know about the disc, normal anatomy, and the physiology of the disc. Next. So disc is a structure where on the periphery there is tough annulus, which is mainly made up of collagen. In the center, there is gelatinous nucleus pulposus, and which contains mainly water and proteoglycans. Next. So annulus fibrosis, which is on the periphery of the disc, it is located in multiple layers, alternate layers at right angles to each other, and these annulus is capable of withstanding any kind of strain in any direction. Next. The nucleus pulposus, which is in the center, it's a distortable but effectively incompressible semi-fluid mass which held firmly in place by surrounding annulus. It mainly contains proteoglycans, which helps in holding the water back. So, and that's the reason why whenever we see MRI picture on sagittal view, if disc is in a good condition or non-degenerated, then we see that disc as a gray or whitish structure. So whenever we see blackish color disc, that means the water content of that disc is low and that is degenerated. So this nucleus is very peculiar in terms of adaptability. So let's say if at all slow pace force is acting on the disc, then it takes fluid-like nature and which has got no memory to the original shape. Whereas whenever dynamic force is acting on the disc, it attains a solid-like structure, which has got very strong memory for the shape. Next. So whenever loads are applied on the disc, the water gets expelled from annulus fibrosis towards the center of the nucleus fibrosis. So as a result, the nucleus becomes abundant in water content and annulus becomes deprived of water to a certain extent, which in early phase of loading. Next. So as a result, annulus becomes dry, stiff, and whenever physiological loading happens in early stages, the disc becomes stronger. The clinical implication is maximum chances of disc injury happens. That's why in a loaded disc rather than unloaded disc. Next. So it has been seen that if we apply Valsalva manure, the disc pressures are high. It goes around 10 to 35% than the normal, and that is the clinical significance of this is whenever patients say that on sneezing and coughing they get radiating pain down their legs, that is because of this phenomenon only. Also, of all the positions, sitting is the position where the disc pressures are highest and least in recumbent position, and that's the reason why patients with discogenic pain and post-discectomy, we tell patients not to sit for long duration. Next. So forces applied on discs can be compressive forces, bending forces, shear forces, or torque like rotational forces. Next. So the range of motion in a disc can be flexion, extension, lateral flexion, torsion, axial compression, but most of the times these forces are applied in a combination matter, but the shear forces are the commonest, which will lead to the injury part. So maximum forces cross the disc is in the position of flexion, and hence the position of loaded flexion renders the disc most vulnerable to the injury. So that's the reason why we always hear from patients that whenever they got injury to their back or to their disc, whenever they are trying to bend forward and try to lift something, so that is the reason why they get injured. So degenerated disc disease is a precursor of prolapsed disc, is nothing but an altered morphology and of the disc, which makes disc unable to transmit load evenly across the vertebral axis. And it results from multiple complex interactions of biological and biomechanical factors, and not a single causative factor is noted. As far as pathogenesis of this degenerated disc disease is concerned, there are three stages, you can say. That is, first stage is there is defect in the nutrition to the disc, which leads to biochemical changes in the disc, and which eventually leads to mechanical dysfunction of the load bearing of capacity of the disc. So disc gets nutrition via diffusion method through their end plates in the adjacent vertebrae and through the annulus fibrosis. Even histological studies have shown vascular buds penetrating through the end plates or the vertebrae and through the outer 1/3 of the annulus fibrosis. Next. So this calcification takes place in these blood vessels, which leads to reduction in permeability of the end plates. That thereby causes impaired transport of solutes and waste products, accumulation of lactates, lowering of pH, and activation of matrix degrading enzymes. These are biochemical changes. Because of earlier two phenomenon, the biomechanical changes happens in terms of pressures. So nucleus pulposus pressures decrease because of these degenerative changes, and that affects the load bearing capacity of the disc. Eventually that gets transmitted to the annulus, where annular fissures start happening, and that condition becomes vulnerable for further disc prolapse. Next. So now we'll come to the types of disc prolapse. So we can characterize or classify disc prolapses in terms of direction wise, anatomical location wise, or amount of disc material wise. Next. So direction wise, which is commonly seen in our daily practice, is posterior disc prolapse, which can be further subclassified into superior migrated, inferior migrated, or central. Anterior, hardly we have seen. Vertical, it can happen within the vertebral body, what we call as Schmall's nodes. Next. Anatomical location wise, here is one axial cut of T2 weighted lumbar spine axial cut. So the orange part denotes the central disc prolapse region. The blue part denotes paramedian or posterior lateral region. The pink or reddish zone denotes the foraminal disc region, and the greenish part denotes the extraforaminal or far lateral disc prolapse. This is anatomical location wise types of disc prolapse. Next. Depending on amount of disc material which has come out, we can classify this into bulge, where there is just outpouching of the nucleus pulposus of annulus fibrosis limit, which is just a bulge, protrude compared to the herniation which is seen in the canal. Content extrusion is the diameter of the herniation in the canal is broader compared to the base of the herniation, and where the annulus is intact. Uncontained extrusion is diameter of the herniation is broader compared to the base, and where annulus is breached. And sequestration is where there is complete disconnect of the extruded fragment with the original disc material. Pseudo herniation is basically, it's not a true disc herniation, because this is usually seen in conditions like listhesis, where because of the offset between the two vertebral bodies, there is pseudo or rather false disc herniation. Next. So this pathological disc is relatively bulky, fragmented nucleus, having fragmented nucleus, and which starts to bear down on the annulus under the condition of loading. That causes expansion of fissures of annulus, and these fragments from annulus nucleus tries to slip out of from their place and tries to go into the canal. PLL resists this central extrusion. That's the reason why we always come across posterolateral extrusions comparatively common compared to the central ones. Next. So what we can expect in terms of these free sequestrated disc fragments, usually the body sees them as a foreign body, foreign material. So our immune system usually attacks them. It has been noted that there are certain neovascularization taking place from the surrounding epidural fat region, which evades these fragments and eventually turn them into a scar tissue, and spontaneous resorption takes place in disc material. The clinical implication of sequestrated disc is most of the times the conservative treatment wise, they do really well whenever we come across sequestrated disc. Next. So if we see the natural history of disc prolapse, most of the times these conditions are self-limiting conditions. 80% patients, they do get better just with good conservative trial. And as a spine surgeon, we have very limited positive role in management of disc disease. And ideally speaking, technique, the success of our surgery also, if at all we contemplate surgery on these patients, 10% is the technique which helps, but 90% of proper patient selection is utmost important. Next. So we'll come to the investigation part. Usually we, as we all know, that usual investigations like X-ray, MRI, and CT. CT is less common, but X-ray, MRI, which is the commonest modality, is what we ask these patients. Next. X-rays are very much important because there can be sacralization issues, segmentation issues, and they help us in proper level or planning of our surgery. Next. Even X-rays give us idea about lysis, listhesis. Next. Next. Vacuum, go back prior. Vacuum phenomena, or sometimes even the calcified disc is seen on the lateral view. So at least you can anticipate that whenever you will go in during the surgery, that disc is already calcified. So for example, on table, if you see calcified disc, and if after decompression of your lateral recess, if your roots are free, then you need not do discectomy for such kind of disc because it's already hard. So it's unlikely to come out further. Okay. So these things can be seen on X-ray itself before going ahead with MRI. Next. MRI wise, obviously the location, migration, exact location. So MRI gives us exact site, or it helps in planning of our surgery properly. IV contrast MRI is utmost important. It has got role in revision cases, or rather cases where we are expecting recurrent disc prolapse, because whenever we do IV contrast MRI in such patients, if at all ring enhancement is seen, which is shown over here, then this is typical of recurrent disc. Whereas scar tissue, if at all it's there at that site, it will be seen as homogeneous hyperintense mass. It won't be a ring enhancement like peripheral ring enhancement. And
Sir, your voice is gone, sir.
Dr. Aditya, your voice is not there.
Sir, please repeat the last few sentences, sir. We were missing your voice.
Dr. Aditya?
Hello, sir. Your voice are not clear.
Just a minute. I'll just check that.
Okay.
What is being shown on the screen right now, I think you all can see that it's a far lateral disc. What happens is very often you see a patient with significant pain, but you go through the slices and you don't see anything in the canal down there. And, you start wondering, but people who have a far lateral disc, you tend to miss it, but you will find it if you study these axial sections correctly and if they're done at the right place. Very often they're not even done at the right place. On the image on the screen right now, the one in the center shows a far lateral disc at L34 on the left, which is dark in color. So it's a more chronic disc. So if you have to go in, you should think of it as there could be a associated osteophyte, and you should go in with the intent of you may have to hammer it down. But the one on the right is a white colored disc. And if it's white, it's a soft acute disc which you'll be able to pull out. Now this disc touches the ganglion, and hence the typical symptom of these far lateral discs is extreme pain, but no neurology. They very rarely get neurology because the ganglion is being inflamed. But the ganglion is not in the canal, so it has space to move. So there's no real compression of the nerve. It's just inflammation of the nerve. That's the funda. And selective nerve root injections sometimes help. The surgical approach is a Wilsey approach where you can directly. Gaurav, the voice is still not clear. Gaurav, everyone is here because we have some complaints about the voice.
There's some reverberation, sir. There's some reverberation.
So.
Taking at this end, sir.
Because I think some other people
No,
are...
now better. Now better.
Now it is better.
So the image on the right is a soft disc which you go in and pull out. The approach to this disc is a paravertebral Wilsey approach where you go from transverse process to transverse process, identify the inferior edge of the superior transverse process, go through the intertransverse fascia, and you will see the disc there if you just fiddle around. The tip here is don't pull out stuff that you see because the neural structure, the neural tissue can get camouflaged because the ganglion, it flattens off. And in my practice, at least once I have pulled out thinking it's a disc and a big nerve root came out. And that can be quite damaging. If you're back, you can take charge again.
No, I think we'll have to connect.
Can you hear, sir?
Yeah.
Can you hear, sir?
Yeah.
Can you hear? Can you hear?
Dr. Aditya, you are joined from two devices. You can leave from one device, otherwise it will echo.
Yeah. Yes.
Yeah, this is fine.
Sir, I think you have. Hello.
Can you hear me?
Oh, no, sir. Your voice are breaking.
Go ahead
Hello.
now.
We are able to hear you now. We are able to hear you now. Please carry on.
Okay. So as already we discussed, Dr. Nene has discussed about the far lateral disc seen on the MRI. So we'll come to the conservative line of treatment. So usually we advise complete bed rest for these kind of patients, supplemented with anti-inflammatory, acetaminophen, and muscle relaxants. Sometimes steroids, neuroleptics drug. Once they're pain-wise, they are better, then we start them on physiotherapy regime, and braces sometimes we give them. After doing all these things, if they are not doing well, then sometimes we offer them pain management. So where the transforaminal approach of pain management is the commonest, what we advise. Next. During all this conservative treatment, we always counsel them on day one. Go back, Harshal, one slide prior. Harshal, one slide prior. So we always counsel patients about the red flag signs, that they have to be very much watchful about the severity of the pain. If at all they come across any weakness in their extremities and any bowel bladder issues, then they have to report to the spine surgeon as early as possible. Next. So as far as indications of surgery are concerned, absolute indications of surgery are acute quadriclonic syndrome or worsening of neurology. The relative indications can be failure of enough period of conservative trial, too frequent sciatica-like symptoms affecting ADL significantly, disc herniations causing severe canal stenosis. Next. So surgical options, we'll talk about this during our clinical case discussions also. It can vary from conventional open laminectomy, discectomy to endoscopic microdiscectomy. Next. Next. So this is one flow chart about the management of prolapsed intervertebral disc. This is published in JC Orth in 2016, published by our own unit of Dr. Shekhar Bhojraj. So we'll be sharing this article post our today's session so that you can go through this, and it will be of great immense help for management of this condition. Thank you. So I'll hand over the proceedings to now Dr. Nene for further clinical case discussion.
And let's have some questions, because Aditya's presentation did raise some contentious issues. And if you all have anything that doesn't fit into the scheme of things the way you practice, at least so far, I think while you're coming up, and just cut me when you have a question, because otherwise we'll keep waiting for each other. My job is to keep talking until someone else talks.
Hi,
So
sir.
any question? Yes,
Sir,
go ahead.
I have a question. I'm Dr. Shatan
Yes.
from Mangalore. I wanted to know what exactly spinal manipulative therapy. Sir had written one slide in conservative treatment. He has done spinal manipulative therapy. What exactly you mean by spinal manipulative therapy?
Aditya, do you buy into this?
Yes, sir. Spinal manipulative therapy is nothing but because exercises given by physiotherapists usually, but there are other professionals also, like chiropractors or osteopaths also these days they come across. But actually this is nothing but the exercises regime what we subject patients to, and it's given by physiotherapists. So they assess the patient and devise customized proper regime of exercises. So this is nothing but the physiotherapy exercises.
And the modalities
So,
which we start in the
hello.
beginning. So those actually, we have some physios joined us.
Yeah.
Please carry on.
So hi, I'm Shikha. So I'm a physiotherapist practicing with VR Spine. So to highlight about spinal manipulations, they are basically turning and twisting of the patient to reduce the disc pressure on the nerve. But now these days we don't practice this. So now these days only spinal mobilizations are given. So these practices like right now are not encouraged by physiotherapists anymore.
Dr. Shatanand, I'd like to bring you to the focus. Have you seen patients who've come to your clinic absolutely locked in their back, and you advise them something, but they go to their neighbor who kicks their back and they come back feeling completely fine? Okay.
Yes, sir. I have seen the patient, sir. Like I practice in a rural area, so I see it very often.
Yeah.
So,
No, even in Bombay, even my father-in-law gets that done. Just
My next
does
question will
anyone
be
have any answer to this? Because this is a kind of an ancient manipulative therapy. So I just want to give my 2 bits in it, because this is existent and it works also. So what happens is that whenever there's an insult to the disc, there's an inflammation that happens locally, and the body recognizes this as a red flag to the nerve, and the body puts all the paravertebral muscles into an acute spasm. That spasm makes the patient present with what we call a locked back. This spasm is holding things down to prevent further injury in the site of the disc injury and further damage to the nerve. If you're lucky, just releasing the spasm will make your spasm go away. You feel great, but it will not restrict the disc, or it will restrict the disc from still further coming out. So some people, they get this manipulation done, they come out feeling free, and then they develop sciatica. Others get away, they come out feeling free, and then never get into a slip disc situation. So that is something that works. So we typically ask the patient to do an MRI scan. If there's no threat to the nerve, there's maybe an HIZ only, we allow them to go ahead with this manipulative therapy. I've discussed this with Dr. Rajshekharan also, who's had personal experiences. I have had personal experience of people who have put them on 2 and 3 weeks of rest, and they've just come with one kick and they've gotten better. Rajan, you had a question?
Yes, sir. Sir, do you advise exercise even in acute conditions like acute pain?
Typically, no. In acute pain, guarding has to be respected. The muscle spasm, which is protecting the problem, has to be respected. And we would not advise exercises. Shikha, do you want to come in here and give your 2 bits about the sliding therapy that you all do?
Yeah, so what we can do is like when patients come with acute pain, the first line of management always goes bed rest. 3 to 4 days max. But then we start with core activation, which involves like activation of internal obliques, external obliques, and transverse abdominis muscles, which we have found their activation itself, which just involves some breathing maneuvers, helps to reduce the pain. So, and then if the patient is presenting with very high pain, SLR positive at very initial degrees, then some nerve sliding techniques have also been helpful to reduce the tension on the nerve. But as such, we do everything on bed without active lot of movements in standing position, unloaded positions basically.
So when you see the spectrum of activities that people advise during an acute phenomenon, there are some aggressive physiotherapists who do nerve gliding techniques where you're doing active SLRs, passive SLRs and nerve release things. And some of them come back saying that it works. Largely as spine surgeons, it's against our logic. So we typically say until the pain is not better, just rest it out. The difficulty starts when 2 weeks down also the pain is not better. And then you're kind of getting pushed to the wall because you know that bed rest starts becoming counterproductive after 8 or 9 days. And that's been proven. So then where do you go? And there's a question before I come to Virendra, who's asked a question. There's a question on the chat box asking what's the use of steroid in conservative management.
I am Dr.
Virendra, we'll just take the question on the chat box, which I think is by Dr. Bandyopadhyay. Harshal, do you want to take that question? What is the indication of steroids in conservative management?
So typically steroids are very commonly prescribed drugs when you have an acute. That's why I had put up in the group also for the poll. So you see complete bed rest versus steroid were going neck and neck. And steroids are very commonly prescribed. But in my practice, typically I give steroids only when there are significant neuritic symptoms, which are not getting better with bed rest also. Or there are significant ganglionic symptoms where patient presents with significant burning sensation in the foot or significant paresthesias. So my indications are that only. And in that scenario also, I try to avoid systemic steroids. I try to give them a pain block. If at all I need to treat them with an intervention. IV steroids I have largely restricted to patients where I cannot give pain block or were not willing for it.
Yeah, so let's get down to the basics. Like a steroid is a very powerful anti-inflammatory. That's all it does. The disc is avascular, so no systemically administered medicine can reach the disc. That is common knowledge. So when you give a steroid, you're causing a powerful anti-inflammatory effect, which reduces inflammation-related symptoms. Now we know that the disc nerve interface causes inflammation because the nucleus is regarded as a foreign body because it's always been hidden from the immune system, and that inflammation causes severe pain. So in the presence of a disc prolapse with only pain, it's okay to give steroids, I would think. But if there's pain and deficit, you're probably doing disservice by giving steroids because you're taking away the safety net of pain and exposing the patient to further harm. So I think that would be my take-home message, that if there's a huge disc with deficit and pain, stay away from steroids, be more legit. We are open to debate because this is not the absolute truth and people have different experiences. So jump in as you wish. But Virendra, can we have your question, please? After that, we'll ask
Yes,
Dr.
sir.
Yes.
Yeah, my question is that we are here having some doctors which are giving steroids along with the xylocaine to the lateral posterior aspect of the lateral malleolus in some patients with acute disc prolapse and sometimes in chronic disc prolapse also. And the theory is that they block the pathways in the ascending tract of the spinal canal so that the pain will be relieved. And sometimes they are also giving in the wrist when the cervical disc prolapse occurs. So it is true. And the second is, what is your experience? Is it beneficial?
Does anyone want to bite that bait? Otherwise, it'll be only me talking, but I can talk before someone else thinks of some better answer. This is the exact same phenomenon of acupuncture. Acupuncture does gating of pain. So when you stimulate a nerve, a peripheral nerve, the pathways can gate the pain and you can get pain relief. Okay. Now, having said that, there is no scientific data suggesting this works. So if there's no study done where in 10 people they've injected on that nerve a specific drug and on 10 people they've done a sham injection, it's unlikely that we can generate that kind of data. But if you think about it, how often have you seen a person with acute radicular pain today, 3 days later coming saying that now my pain is much better? So the natural history of a disc prolapse is one of, getting better. It's one of self-resolution. And anyone who puts his hand during that phase, if it's Baba Ramdev and his Bhasma, then he gets the credit. If it's the guy doing the injection on the posterior tibia nerve, that gets the credit. So I think as men of science, we would not advise that unless these injectors get some, some data. Having said that, there are people who I have seen, and you have seen, Virendra, who have come with improved, with benefit with that injection. So if someone's gunning for it, I say, please go ahead and take it, but there's no science. Does anyone have anything else to add here? Any other experiences?
Sir, I'm Dr. Bharat from
Yes, Bharat.
Hyderabad.
Of course.
Sir, here in the first for cervical radiculopathy, I have seen a video of Dr. Satish Chandra Gore, sir. He was explaining some basis for that. That in the wrist there is some nerve ending which gets stimulated, and by giving the block, by giving xylocaine injection, and in the meantime we can before we get the MRI done or whatever the investigations we need, for the time being we can use it as a pain block.
Yeah. So, Bharat, these theories have been said, but the results of these, interventions are 50-50, like a toss of a coin. So what is presented to us is the good results. And what ends up coming to you as a surgeon is the people who have had this, like I would say a dime a dozen of people who have had this, had decompression therapy, have had manipulative therapy, who have not done well. So I think it's the lens from which you view. So I'm not contesting Dr. Gore's claim, but he will need to prove this in some forum where he can do a control trial, or at least present prospectively, 20 patients who've had this with the same pathology, and then 50% or more getting better. It's the same for ozone. You all must have seen ozone injections being used for disc. Again, it has absolutely no scientific value, and nobody who injects ozone without lignocaine and steroid. So how are you sure that it's not the lignocaine and steroid, which is a known time-tested technique, is not acting and the ozone is acting? So I think that is where we stand right now. Shashank, you had a question.
Sir, here the thing is,
yes,
sir, here I have been giving in my OP practice, I have been giving injections, xylocaine injections in the sinus tarsi and in the mid calcaneal upper border on the lateral side.
Yeah, and it works according to you?
The thing is, sir, rather than a curative therapy, it must be looked at as an analgesic
as a symptomatic. Sure.
Analgesic therapy.
Sure. So, Bharat, it is very interesting because, it's interesting to hear this. I would actually encourage you, because this would help all of us, that you actually record the data of the next 25 patients in terms of their pathology, in terms of their either pain score or some kind of a VAS score, and prospectively see what happens when you do it. And the truth might come out. And if you really have a strong point there, saying 8 out of my 10 patients reported more than 50% reduction in VAS scores within 24 hours, then I think this is a paper that will actually get at least read in a good podium or published. And I'm happy to collude with this. I can I can in our practice use your method, because we have tons of patients, and help you build the numbers. Yeah, Bharat.
Yes, sir. The thing is, what I want to say is it should be seen as a analgesic therapy, sir, not
Absolutely.
as a
But even if it's analgesic, it's a huge bonus, right? Because we are doing spinal injections, which are far more interventional. If you're able to do this in the outpatient setting and getting a good result, I think it should be seen as a as a bonus. Shashank?
Shashank, yeah. Yes. Sir, I have had a question about what is the exact role and what is the indication of using neuroleptic drugs and antidepressants during a conservative management?
Aditya,
Dr. Aditya, you don't want to take it?
So neuroleptic drugs are basically they are not, first of all, painkillers. They are nerve modulators, you can say, because and antidepressant. So there are pain pathways. Basically, they work on those types of pain pathways and alter the perception of the pain, not exactly acting as analgesics.
So there is something called centralization of pain, and people who practice pain medicine believe that if there's a chronic pain, it can create a impression in one of the sectors of the brain, and the brain cannot forget that. And these antidepressants are supposed to work in that. Again, personally, I would advise you not to get into it, because if you don't have the knowledge and you give an antidepressant, a knowledgeable patient is going to get back at you, because this is a mechanical problem. We are orthopedic, trained surgeons. We are not psychiatrists. So personally, I would not use antidepressants. Of course, neuroleptics means gabapentins, etc., because they're the standard of care, proven standard of care. But antidepressants in a disc prolapse, I think, is beyond our reach. It's you're biting too much than you can swallow. Mustafa,
So it is always better to go.
yeah, Mustafa first, and then who was saying that? You can say.
I'm Bharat, sir. Bharat.
Yeah, Bharat, go ahead.
Sir, the thing is, in my post-TKR patients, some people who have been with gross deformity and suffering from a lot of time, they come to me with pain even after TKR.
Yeah.
The same kind of pain. In those patients, what I've observed is gabapentin works well. They, as you said, that central sensitization syndrome, central sensitization, that cycle is broken. And second thing is, when we give this antidepressant like nortriptyline or amitriptyline in small doses, the thing is the patient sleeps well, sir. Because of which his mind is calmed, basically. That's what I observed. Because of that, he will be happy. That's what I observed, sir.
Yeah. So you're absolutely right, but I have a problem of educated patients coming back and saying that, look, he's given me an antidepressant. Does he think I'm... So you have to be careful when you do, this kind of therapy. You should have some backing, or you should tell the patient upfront that, in my experience, it works. So I would like to try this. It may cause you some drowsiness, but it may help your pain. If you're up for it, please take it. Because, today the class of patients are pretty well read, and they do research, and they go and check their prescriptions on Google and come back and tell you. So I think today in 2023, we should at least disclose this to the patient.
Yes, sir.
Agreed. Mustafa?
And sir, one more question. When do we go for selective nerve root block, and when do we go for caudal epidural steroid injections?
Yes. So we'll address that. Maybe
sir.
Mustafa. Yeah.
Hi, sir. Sorry, I just got in and I heard about that neuroleptic drug. Can I just add a bit about it?
Please.
See, basically, over the years, I've done a little bit of research on what are the different types of drugs that we can use if we have to use. And the issues are, since we are surgeons, we really don't understand the basis out of it. Typical neuroleptic drugs or antipsychotic drugs, they are going to work in this chronic patients because they are going to work with blocking your dopamine receptors, the uptake receptors. So they give you that happy feel. Few of the drugs which are absolutely safe for us orthopedic surgeons to use are duloxetine, amitriptyline, pregabalin, and gabapentin. Just few rules about them are 10 milligrams. Amitriptyline is completely okay to take. Like what Abhay sir said, you should tell them that it's a 25 milligram dose is used as an antidepressant, but a 10 milligram dose will work as a nerve modulator. Duloxetine works well, but you should not give it at night because it messes up with your sleep cycle and patients get a lot of palpitation. So if you want to use duloxetine, you should give it in the morning hours. There is no scientific basis for combining gabapentin with pregabalin. Like if you are using pregabalin, you should, if you want to increase the dose, you make twice pregabalin. A lot of times what we do a combination of gabapentin, pregabalin and all. And if you actually look at the pharmacological way, they don't work well together. So gabapentin with nortriptyline works very well. Amitriptyline alone works very well. Pregabalin works well. Pregabalin, gabapentin give at night. Duloxetine give it in the morning. And generally try to taper off these drugs. Apart from this, there are those other drugs which are antipsychotic like haloperidol and all, which honestly we don't touch because it can cause issues when you withdraw them. So that is best left to the neurologist.
Lovely. Mustafa? We've been waiting for long.
One more question.
Thank you very much. I'm from Kenya. My name is Dr. Mustafa.
Yes.
I wanted to ask, how long do you keep these patients on rest? Mainly, they are from workplace. So how long do you give them off duty? That is sick off. And the other question was on laser therapy, PLLD. Do you advise PLLD or you don't advise any patients on PLLD?
All right. Who wants to take that about bed rest? Otherwise, I'm always there.
So bed rest actually, for us, we typically tend to advise for 3 to 5 days, not beyond that, because they're a young chap. Typically, the disc is a problem of a younger generation, not the older generation. They have stenotic and claudicating symptoms. But 3 to 5 days of bed rest, in my practice, I typically advise. If beyond that the patient is not getting better, then I try to add some pharmacology. Initially, I don't add. And if after that, I always tell them that you should curtail your activity. You should not get back to your full swing of activities, because then we want to observe with the increase in the mechanical activities, the pain comes back. And that's my protocol. Secondly, coming back to the laser, I personally have no experience, but if anyone wants to take up that.
I can take that up. So as far as laser is concerned, we've used it in the early 2000s. Laser is a modality of, it's supposed to work in multiple ways, but the way it was supposed to work was it was a sealant on a HIZ. An annular tear could be sealed using a laser, using the, the coagulative laser. And it was a ND YAG laser that was being used. Now, as we did more and more cases, we started same thing, laser along with nerve root injection, laser. And then we started realizing that the laser was doing very little. We have not done, Mustafa, we have not done PELD, but we have done nucleoplasty. When in my time, nucleoplasty became a very, common thing. It was not chemonucleolysis, it was physical nucleolysis. So I have done maybe close to a dozen patients where we've stuck in a, tube into the disc, manually broken it down and sucked it out, pretty similar to PELD. Again, this is known not to work because the way this was supposed to work, that it was supposed to create a vacuum in the disc and suck in the annulus. Now, because the disc is so disintegrated and it has no internal pressure, this technique does not work. So to cut a long story short, laser discectomy or annuloplasty and PELD or intradiscal procedures have now completely been discarded, and we should not be advising them. And there is data suggesting that they don't work. And in fact, there's data suggesting that it can create a disc degeneration. The Canadian authors have proven that sticking in needles and things into the disc can actually shoot off a disc, degeneration. As far as pain relief from bed rest comes in your practice, you will see roughly 3 categories of people with an acute lumbar disc prolapse with sciatica. One who gets better in the first 3 or 4 days or a week tops. Another who takes about 3 weeks to get better. And the third category who just lingers on. And your bed rest has to be tailored to that. So typically, most of us in the first week with, the first few days of rest, if he's not better, we straight away put him into the next category and start talking of doing injections and stuff, because statistically also the longer he or she is going to take to get better, the less likely he's going to get better with non-surgical treatment. So if the patient has a pressure of time, after 1 week, we would start talking to him about injections. As far as your question was, how long will you keep the patient off from work? That totally depends on the patient's work profile, his capacity to work. But one thing's for sure, that it has been proven that actually bed rest does not work. It is time that works. And the concept of bed rest is just to keep the patient away from unruly activity. So if I had a sciatica, I would be mobile, but work within my capacity, trusting my own instinct and my common sense. But we don't trust our patients to do that. So we say take full bed rest, which means that if the patient is in reasonable pain, but he says, look, I can go to the office and manage, and he would like to do it, then you would encourage him to go. But if he's a manual laborer, it does not make sense, because he's not going to be able to bend over and lift 40 or 50 kilos. I hope that answers your question. Vishal, you have a question, I think. Or if is anyone else on the anvil?
Abhay sir.
Yes, Nitin.
Hi, sir. Sir, I have 2 questions. So number one, so when it has been shown in the slides that there could be a disc which could be just a disc bulge, and then there are certain severe varieties where disc is sequestrated and then there is a separate portion. So is it just the evolution of the disc severity, or it's not evolution of severity?
So this is a disc injury. It's like when you fall from a height, you could either snap a ligament, strain a ligament, or break a bone or dislocate a joint. So the only preamble to a disc prolapse is a degeneration. A healthy disc cannot prolapse. So the preamble is that over time, that specific disc for unknown reasons starts to dehydrate, loses its sponginess, becomes less rigid, and starts losing its shape memory. Such a disc is prone to injury. So when this disc is overloaded, at the point of overloading, depending on how much the load was and in what direction, it can either just have an annular tear, or it can bulge out, or it can actually open up and extrude, or it can get shot out and sequester. So it gets shot out and then finds a way somewhere else in the canal. So it's a gradation of the injury that happened on day one. You will rarely ever find a person who has an extrusion which has now gone up, in 2 weeks and gone migrated, unless he's done something foolish. Nitin, I hope that answers your question.
Got it, sir. So second question is, sir, when we look at the younger population, this degeneration is usually L5S1. But as the age increases, the degeneration occurs on upper level. Sir, any pathophysiological, sir, reason why it is so, sir?
Yeah. So actually, I would disagree that uniformly across the board, 60% of disc degenerations happen at L4-5. And of the remaining 40-30 happen at L5S1, and the rest is distributed in the rest. But if your experience says that younger people have a lower disc degeneration, it may be something to do with the anatomy, because younger people should not have a disc degeneration. So if they have some kind of aplasia in the lumbosacral joint. But I don't know, anyone else in the crowd has had this experience of younger people having DDDs at L5S1? Or anyone else, Tosif or Kumar or anyone else? So we, Nitin, that part we will.
Sir, I'll repeat. Sir, what I could gather is that you say literature-wise, L4, L5 disc is more common across the board, maybe 60%,
yes.
And then the rest is all divided anywhere, right?
Yeah, I mean the second most common by far is L5S1, and the rest is then divided.
Okay, sir. One more thing, sir. And that's the last. And sir, when it comes to these disc degenerations, so could there be some sort of, I was wondering, some sort of micro motion occurring between two vertebral end plates that contributes to the degeneration, but we are not talking about listhesis per se.
Yeah. So I think you have a theory, and a lot of people have worked on the following theories for disc degeneration. One of those was micro motion at the end plate, causing blockage of of like Israel ka Gaza Strip ko supply band ho gaya, that types.
Right.
Diffusion goes away. But the other theory which Dr. Rajshekharan has been working on is infection, low-grade infection as a cause of disc degeneration. But today we don't know, because none of these theories have been propounded, and you will see the most heavy and physically active guy with no degenerated discs, and the most light and physically fit guy with degenerated discs. So we don't have an answer to that.
Got it, sir. Thank you, sir.
Thank you, Nitin. Any other questions? See, this is our forum, guys, and I'm not the only guy with knowledge. So just please.
From Jharkhand, I have two questions, sir.
Yes, Vishal. Is
Hello.
That you? Yeah, Vishal.
Sir, I have the two questions. First, about the braces. Could you provide some detailed information about the braces? How much time it has to braces, and what type of braces to be used? Secondly, sir, because there are a lot of people, so I'll ask meanwhile the same question. Second question about the management, conservative management. How much duration before surgery we should go for the conservative treatment?
Priyank, do you want to?
Yeah. So braces on a short term, the one that actually works is a lumbosacral belt, a flexible brace. The idea of the brace is not for a real back support. It gives a quick support to your abdomen. So someone with a flax, loose abdomen, when you give them a brace, it tightens the abdomen, and that gives an immediate false support to your body. Long-term use of the brace is not advisable, because then the core does not remain activated, and then gradually they do lose their core muscle function. Conditions where there is instability, it has shown that a frame type rigid belt helps. But again, in today's day and era where rehab has taken a big advance, there is clear evidence that stability training works better than braces. So in the initial phases, yes, brace has a role, but long term it has to be discouraged.
And at the same time, somehow I feel that whenever, especially in post-op patients, whenever we ask them to put brace, it's just like it's kind of a reminder to them that something has been done to their back. So they'll be more attentive to their posture, how they are moving forward or bending forward. So it's more of a psychological thing also, especially in post-op patients. And whatever Priyank said, I agree with that.
I hope that answers the question. And look, our forum is going to be active 24/7 for as long as you wish on the WhatsApp. So just keep pouring in the questions, and we'll try our best to answer them as much as we can.
Sir, I wanted to make one comment.
Yeah,
about
Aditya,
the
you can make the comment before Gyaneshwar asks. Yeah, Aditya.
Yeah. So, in my experience, the earlier question asked by one of the delegates about the level. So, in my experience, I have seen L45 level. I have seen more of a disc degeneration, and my theory or maybe experience in that is somehow I feel that most of the times whenever we see those patients where 4-5 disc is degenerated, and if you see their X-ray, L5 is well settled. What I mean by well settled, that if you see the iliac crest, it has sunk below the level of iliac crest. So L5S1 disc is quite stable. So the more movement or load is happening at the L4-5 level junction. And that's the reason in my practice, at least I have seen L4-5 level disc degeneration very common compared to L5S1.
Sir, can you once again repeat the reasoning, sir? Repeat the reasoning. Some stability thing. Can you repeat, sir?
So L5 vertebra, many times, if you see the AP X-ray, L5 vertebra is seen below the level of iliac crest. If you join on AP view iliac crest, you see L5 vertebral body is below or settle below that level. So that means that inherently the L5S1 disc is well preserved. Okay, so whenever movement is happening, that is movement is happening more at L4-5 level rather than L5S1 level. In cases where L5 vertebral body is well settled, as far as the iliac crest level is concerned, and that's the reason why that leads to more degeneration at L4-5 level. That is what I have experienced in my practice.
So as spine surgeons, we should always look out for a low-lying L5 and a L5 that's standing proud. The low-lying L5, which is below, as Dr. Aditya said, the level of the iliac crests, the transverse processes are kind of merged with the ala or with the ilium, and this seems to be a less mobile L5. It is almost like a sacralization of L5, and these people invariably have higher load transfer at L4-5, leading to either degenerative listhesis or leading to disc degeneration. This is important because if you're operating on that person's L4-5 disc, you probably want to view it with suspicion, as it's a covert sign of potential instability. I hope it's clear. Thank you, Aditya, for getting that point in. Gyaneshwar followed by Venkatesh. Gyaneshwar?
Sir, good evening. I'm Dr. Gyaneshwar from Visakhapatnam, sir. So I have this question regarding the studies that were put in the group. So most of them say that the long-term results of with radiculopathy, treating them conservatively is almost same as going for surgery. So sometimes I'm sure in all of your practice, you would have seen some patients coming back after 4 years, 5 years. They have MRI scans from 5 years ago. So where do you draw the line? So do you tell the patient that, okay, even if I do the surgery now, long term it's going to be the same as this? But you definitely have a group of patients who keep coming back with repeated MRIs. You know, they have a pain relief with some injections or medication, and keep coming back after 1 or 2 years. So when do you decide, or how do you know when to operate?
So that's a great question, Gyaneshwar. At least in our practice, because we extensively treat discs conservatively, we have a protocol where if the patient gets better, he's kept on regular follow-up. He's not discharged from OPD, and at least 3 monthly he follows up for a rehab, from a rehab perspective. So we monitor his rehab. We keep whipping his back for do's and don'ts. And at the end of 1 year, he's been already primed that even if he's fine, he has to do an MRI and come back. So 12 months from his start date of conservative treatment, we do an MRI. Why 12 months? Because most studies show that the optimum time for a disc to resorb is 12 months. It does not mean that it will not resorb after that. It does not mean that in 3 months you will never find a resorption, but average is 12 months. We normally prime these people that if you're symptomatic and you have a disc prolapse at the end of 12 months, which has not gone away, we would still talk to you about surgery. If you're asymptomatic, we don't discharge you from OPD. We still keep you followed up and maybe even annually do an MRI scan. Now, how desperate this guy is wants to avoid surgery determines how long he wants to wait. But as long as there's neurology, I have no business to push him to doing a surgery. I hope that answers the question. Any other thoughts? So, Venkatesh, you have a question?
Sir, a very similar question, sir. Acute disc, the relative indication was, the first indication was failure of conservative trial for long enough period, sir. How long is long enough for an acute disc?
Harshal, you want to take that? What is your link?
So basically, for me, it's more of a patient profile and patient's demands. If patient is not able to perform to the demands which he wants to perform to a level, I would escalate my treatment. But if patient has time, patient is largely getting slowly better and he's happy with the treatment, I would not intervene early. So after saying all this, technically we say 3 months is an optimum kind of a thing, which all the books mention, but it's more dependent upon patient's demands and patient's profile. Yeah.
Yes, sir.
Gaurav, do you Gaurav?
In the MRI that we get for the acute herniation, is there any role of the canal diameter in deciding between conservative and surgical approaches?
Yes, Harshal, you want to take that?
So I've not found that because I've sometimes, this is my personal experience and I would share here in this forum. But the big disc, good morning disc comes to the OPD and I tell them, boss, you will require a surgery. And after a week, he comes to my OPD, says there's no pain at all. So that has been my experience. So, and if you see actually that other paper which was put up on the group, the large sequestered disc has a better chance of resolving completely.
Yeah.
So for me, I have not found the correlation between the amount of disc and the decision making for surgery.
Having said that, I think we should keep our eyes open for what is called as primary lumbar canal stenosis. People with primary stenosis have smaller AP diameters of the pedicles, and these guys, more than the canal diameter, they have shorter canals. This is a uniform stenosis across the entire board, and they have even a small disc that can be very symptomatic. So in a way, what you're pointing out is potentially possible, but that's a primary lumbar canal stenosis which presents as a lumbar canal stenosis with a superadded radiculopathy.
Yeah, very true.
Even the level at which this disc prolapse is happening, that is also important, because sometimes L5 means football like disc also can be accommodated well within that canal, whereas same size disc, the prolapse, if that happens at higher lumbar level, L12 or L23 level, those patients will come up with quad eye planar syndrome. So, at what level this prolapse is happening, or disc also can trouble you rather than the big disc prolapse. So it depends on at what level, at what anatomical location that prolapse is happening.
Perfect. Shikha, your question?
Yeah, so I want to know, as a surgeon, when patients come to you with discogenic back pain, leg pain, so we always say that we gave some don'ts to follow, like avoid forward bending, the long sitting, slouch sitting. So when patient recovers, so we have already seen a pathology on MRI. When do you allow patient to do forward bending, weightlifting? So because this is something which, every patient keeps asking me, and there are a lot of relapses even after they recover fully. So when should we allow a patient to do full forward bending, weightlifting, everything?
Who wants to take that? Personally, I allow them as soon as they're comfortable, as long as it's not recreating any neural symptoms or the symptoms they've come with. I would not allow them. I normally tell them, or in my practice, I would educate them on what are the movements that increase the intradiscal pressure. So low sitting, slouching, reaching out. So we say that avoid it or be very careful when you do it. And the meaning of careful is you tighten your abdominals and tighten your pelvic floor, and then in a coordinated manner bend forward. But I would not debar them from bending forward.
So is it like we wait for a change on MRI after a year where we allow them to do as like normal people are doing, or some precaution they have to take lifelong?
No. I mean, the do's are lifelong. The don'ts are not lifelong. The do's of rehabilitation are lifelong, but there's no lifelong don't. And I'm saying this out of experience of, treating international cricket players who cannot not bend. So once they've come out of their, out of their radiculopathy, they need to get back. So if they're fit, they're okay. Even runners, people who are long distance runners, for them, their normal is running. So in our heads, running means it's going to cause but they are used to it. Their muscles are used to it. So in short, we just go by a clinical profiling.
Yeah.
So you allow.
Yeah. I actually look at their paraspinal spasms and give them that guidance. Like if their body allows them to bend forward, they are not on any muscle relaxants or any modalities, they are okay to bend forward. If they feel stiffness, paraspinal tightness, that's an indication that the disc is getting loaded and it's not happy to do that. So then it's off. And especially when we are treating these discal patients, prolapse intervertebral disc patients, we should seriously avoid any kind of passive increase in range of motion for that patient, because as the discal injury heals, as the disc becomes normalized, the body automatically gets flexible.
So we should allow them to do forward
Yeah,
as well as
if they're not
backward
on any modalities, if they're not any muscle relaxants and they're comfortably able to bend, let them bend. If the back gets stiff, then they should start bending from their hips and knees. So do something like a lunge with a supported, with the hand supporting on the knee. So yes, you can.
So we can probably squat and then, pick up something. But my question was like, after the episode is settled, so should we allow them free bendings? We should, na?
Yes. Even
Once they're
post-op, we
rehab.
allow them. Post-op also, we allow to bend fully downwards.
Yeah.
Umang,
So, and do we guide them about a right or a wrong posture? What is the right or a wrong posture? Should they maintain lumbar lordosis while sitting down? Or is it like they can sit in the position of comfort?
So actually, when you do the rehab, instead of asking a patient to be upright and have a very good tight posture, it is a passive muscle memory that corrects the posture. So you work towards muscle strengthening and the posture auto corrects rather than telling them to constantly adopt a posture. So I think the correct answer is to sit in the position of comfort. Of course, not sit in bad postures like a very crouched thing. Like if suppose a patient has a tendency of crouching, it's better to have a back support. But generally, active posture corrections are better is to work on the muscles and get them a passive muscle memory, which actually tones up the muscle and holds them in the right posture.
Okay. So basically what I have been following is like guiding them about the center of gravity, how they should maintain. Otherwise, they are falling, they're slouching. So I just wanted to know, because most patients keep asking me what is the right posture, and it becomes very difficult to sit in the right posture.
So one of the most important theories is the biomechanics.
Let's shift this discussion because there are many people. Umang, your question?
Sir, one suggestion. Umang, just a minute. In the interest of time, should we ask them to put up questions on the group and carry on with the clinical discussion?
Our discussion, Harshal, will be based on all this only. So on one end, what I could do is just put some slides up, but let's keep taking questions because this is what do you think, Priyank? Aditya, what do you think?
Yeah, I think questions specifically relevant to our clinical topic, we should just keep taking because that's how the discussion is basically what we are here for.
Yes.
Agree, sir.
Yes, Umang.
Sir, what is the role of doing an MRI at 12 months if the patient is asymptomatic? Like the protocol which you mentioned, where you do an MRI after 12 months.
Yeah.
So if it is asymptomatic, how is it going to benefit in any?
This is not evidence-based, and I'm not suggesting you need to do it in your practice. But I must tell you that we treat a lot of patients with disc conservatively. So at any given time, there is like 3 or 4 dozen people who are of a surgical disc who are on a non-surgical protocol. And at least 80% of these guys want to know what's going to happen by waiting and when will the disc go away. So over the years, we've, by reading literature also, though it's not strongly evidence-based, we made a protocol of doing, of rechecking on an MRI where his status is at the end of 12 months. At the end of 12 months, even if he's asymptomatic, you get an MRI scan done. There'll be 3 outcomes of that MRI scan. One is that the disc is completely regressed, in which case any further disc prolapse is a new disc prolapse. So I think Gaurav was mentioning that they keep coming back. So if he's been fine for 2 years and his disc has also disappeared, you treat the next episode at 3 years as a fresh disc. And in fact, he's got a good track record. So there's a good likelihood that he's going to get better. You can't, I know you're in practice, so you would know how desperate people are to avoid an operation. Honestly, we are very conservative because we are not in the, so basically create a situation where our conservative treatment has worked. The other situation is that the disc has not regressed. It's the same as it is. And there we tell him, okay, bro, you are fine, no pain. So there's no question of intervention, but your disc is still there and we still worry for you. and you need to be following up, which means that we just tighten the grip on the trigger and say that you better be doing your rehabilitation and following up, etc. The third is where the disc is actually worsening, and here there could be a threat because they could be covertly hiding symptoms or whatever, and we kind of spell it out. Again, we would not offer surgery based on an MRI scan, but at least we have a expectation setting done based on the MRI. I hope I'm able to convince you on that.
Yes, sir. And second question was, as you rightly mentioned that every disc prolapse is because of a degeneration. Do you think that it is wise enough to, these individuals with high activities like cricketers and all who you've actually treated, like if they get back to their own the original activity, do you think it's going to only worsen, like degeneration worsens as age progresses, and if your activity level is going to be the same, the problem is just going to be compounded? It may be
Absolutely.
solved
So
right
that,
now.
again, you nailed it, Umang. The tagline that we use is that now that you're out of this problem, you have to do something different to not get back into the same problem. And the example we give is that, look, you were smoking and you got a heart attack. You fixed your heart. Now you stop smoking. Otherwise, you're going to again get a heart attack. So it's exactly the same. So for the low demand individuals, we just put them on a regular, protocol of rehabilitation, which has been described. Weight control, building of the torso muscles, correct postures, and, building up on their endurance. But on cricket players and sportsmen, what we've extensively found in our country is that there's a very poor approach to trunk building compared to sport fitness, which means a swimmer will be practicing swimming for 7 days a week and would be doing physical training or self-training for like half a day. Ditto for a cricketer. He'll be hitting the shots, but not working on his own fitness, barring a few. So we make them aware of that, and we use machines and, devices to, blow out on their face how weak their trunk is compared to the kind of loads that they're using. So basically, we set them on a much higher level of rehabilitation to prevent re-injuries.
Oh, thank you.
Virendra? Thank you. Virendra?
Sir. Yes, sir. I am Dr. Virendra Shukla from Ahmedabad, and I want to ask a question that what is your message regarding epidural steroid injections? We treat conservatively patients with bed rest, and then if patient is not getting better, then we advise to give epidural injection. How much time, how frequently we should give? And sometimes spine surgeons tell that after giving epidural steroid injections, the scarring occurs around the spinal cord. So it is not advisable. So what is your message, sir?
Aditya, Harshal?
So basically, if you're using depot preparations, the scarring is more. That is what is described.
Yes.
And in our practice, I do use depot. But then I restrict myself and I tell my patient that if you're requiring frequent injections, might as well get operated than keep taking frequent injections. But people use methylprednisolones and all also, and they are supposed to not cause a lot of scarring. But any which way, steroids are kind of the fibrogenic, so they do induce some amount of scarring. Coming to your first question, where how often and this thing, so I myself have given one patient 6 or 7 injections, but then she was hell-bound that she doesn't want an surgery, and that was the only reason I would have operated her otherwise. And I don't use more than 2 or 3 injections per se, but that is my personal opinion. There's no evidence that we cannot give. We can give as many as you want.
Even in my practice, always once I give patient at first consultation, complete bed rest, medications and everything, at that time only I prime them about transforaminal steroid injection. So I always tell them that once this first stage of rest and medications, if that is not helping you, then obviously this second option is always on. And max to max, I believe in giving only max to max 2 injections, because I believe that more than that, it may not help that early, because earlier 2 times it has not helped. So this is my personal opinion. Again, this is not evidence-based or literature-based. And I've used triamcinolone rather than depot for giving transforaminal injection.
And one more point, I typically make them, I sensitize them that this is just a getaway. We are reducing the inflammation on the nerve.
Correct.
and this is a very trump card which you're using. So use it wisely and make use of this time when you are pain free, when the inflammation has gone down. Really work hard on your rehab so that the duration of the symptomatic relief or maybe rehab building is much better.
Absolutely.
Anyone else?
Sir, do you give muscle relaxant to all the patients during conservative management?
Use of muscle
relaxant.
So muscle relaxant, it's again sometimes it's depends on the patient's work profile. As Abhay sir earlier said that we have to look into consideration their demands, the profession, how early they want to get back to their profession. So rather than having a fixed mindset about whether we have to give muscle relaxant to all patients or not, it has to be a custom-made thing. So in my practice, I need not give that muscle relaxant to all patients, but anti-inflammatory for sure and neuroleptic for sure. These two things are must in my practice. And muscle relaxant, depending on patient profile, his demands, profession, I take a call.
I just want to ask one question, sir. Basically, for the interest of this group, how often do you take CT scan in case of PIBD? And has it increased in last couple of years for you?
So I think on that note, Harshal, let me break into at least one case just out of interest because like you said, the time is running out, but there's lots to discuss. Okay, so...
So till you just put it up, there's one interesting article which just came about, which actually Dr. Ayush Sharma has just published on where he has shown that there's increased incidence in wound issues, CSF leaks in patients who have received an epidural injection before the surgery.
Wow, so that's some data, but I mean,
then it's not a very high-powered study. But at least it does show that repeated injections has a higher incidence of CSF leak syndrome.
You've got to think about it. I have personally felt higher incidence of infection. That's what I tell my patients.
Yeah.
And instead of intra CSF leak also. Okay, here's a with significant radiculopathy. Guys, anyone who wants to take a bite at it? No deficit and radiculopathy. What do you see here? Mustafa, can you say what you see here? Are you able to see the screen? Someone? Yes? Anyone okay?
Alpha S1 superiorly migrated disc.
Okay. And would you call it extruded? Would you call it in your language? What would this be called?
Yes, extruded.
Sequestrated. It's gone behind the body. So this would be the classic sequestrated fragment that's gone from the bottom up into the body. Okay, behind the body, and this actually hits the axilla of the upper nerve root. So a lot of these people come with L5 radiculopathy rather than S1 radiculopathy, and they sometimes even have a deficit because, as you know, a disc that goes into the axilla stretches the nerve root. A disc that goes on the shoulder, there's some play for the nerve root to go down. So axillary discs are known to be painful and they cause deficits. Okay, how would you proceed here? So this guy has no deficit. But he is howling in pain. You've tried your conservative management. It's not worked.
Selective root block.
Okay. Anyone else for anything else?
So I think depending on the age, if he is active individual, better to go for either endoscopic or microdiscectomy so that we release pressure, and morely endoscopic because he will have less morbidity because the incision will be less and we'll be able to identify the root easily.
So you just, Shatanand, I'm glad you said it. I was waiting for someone to walk in the trap. I'm not picking on you. Anyone else for this approach? A micro or endoscopic or an endoscopic for that matter at this point? I'm sure many of you would be interested in an endoscopic discectomy here because it is a big disc. Let's assume that he needs surgery. Okay, so we are just going away from the injections and bed rest. If he needs surgery, what would your approach be? Shatanand already put his cards down. He said it would be an endoscopic discectomy. Anyone for any other procedure? Anyone?
I would would go for a microdiscectomy with a superior a level up exposure
Yeah.
so that we can easily reach to the axilla of the L5 nerve root.
Okay, so your choice of
Rather-
microdiscectomy is based on your training or based on the fact that you would get a better exposure of that area because the disc is migrated up?
a better exposure of the disc.
Right.
would
So will
help.
what do the endoscopic guys feel? Adele, Kumle, you can speak. Nitin, you can speak. Anyone can speak at any point. I'm not in charge of this forum. Just butt in and speak, okay? If it's regarding this case, if it's
I think we can get a good exposure with endoscopic is what. But like I am not trained in endoscopy, but I have worked under one sir who has done endoscopy. In that I've assisted some around 15 cases, which I've seen that we have a better visualization and there's more zoomed in images compared to what we see in microdiscectomy.
Right.
So that's why I felt that endoscopy would be a better option. And
totally fine. Totally fine. So we have endoscopy, we have microdiscectomy. Any other options?
Sir, am I audible?
Yes, sir.
Yes. So two things basically. The T2 weighted MRI, it also shows modic changes at the L5S1 joint. And if I look at the facet orientation of L5S1, there is, of course, facet tropism. So there is the third thing I would like to point out is like it looks to me like a hard on the soft disc because the on the T2 weighted film, the lower part of the disc is completely black as compared to the softer part, which is migrated superiorly. So can we have the X-rays, dynamic X-rays, and like CT scan is in the line, I hope.
Right. So now here we are talking, and because Dr. Harshal asked that question, I put this case up to see what happens when you get a CT on this patient. Can everyone appreciate what's going on? This is a grossly calcified chronic fragment. I don't know if you can see it here. This is
very well appreciated, sir. Very well appreciated.
You can see it here. And this is like a killer disc, as we say, here you go in with an endoscope and you just hit the wall, can you see this here? It's the whole thing lying there.
Yeah. Yes,
Even
yes.
with the microdiscectomy. So I've had the misfortune of creating a deficit. So this is back in the day in the, like maybe the year 2000 that I got into a case of my senior associate saying that you do microdiscectomies, please go and do a microdiscectomy. I had no clue of the patient. I did not know what the patient's profile was. And I went in and it was this kind of a completely calcified hard disc. And when you have such a small opening, you're struggling retracting the nerve roots, which are actually stuck on this. And it's in your interest to actually open up and do a laminotomy and, go on top of the nerve root and, osteotomize this down. But of course, at that time, I was 23 years younger and I just struggled and eventually got it out. But the patient had a foot drop post-op. So this is just a lesson learned. Of course, there's no lesson here because I'm not sure if I had, I had planned a surgery for this patient. I would have done a CT scan pre-op. We don't end up doing CT scans as often as we would do in a cervical disc in the lumbar spine. Mainly because most of us, I know a lot of the younger people are practicing endoscopy, but most of us practice microdiscectomy. And we normally tell the patient that the incision is not we never promise you about the size of the incision. So intraop, if I find it's a hard disc, I just open up and remove as much lamina as I need to, but do the right surgery. I'd like everyone's comments on this because this is a unique situation and you can imagine yourself on the table and you hit this kind of a disc. Any thoughts? Anyone has anything to say? Adele, Kumle, yeah, Umang, yes, anyone?
So, sir, I had a similar case which I had just operated 2 weeks back. But in that case, it was an L5S1 down migrated disc. So, what I wanted to know from you is that when you go ahead in such cases, do you use a small osteotome to enter the disc base, or you just do a nerve root decompression and come out? Do we actually make an attempt to remove these discs, or just do a good decompression of the nerve root and
that does not work unless you unlike the posterior cervical surgery in the lumbar spine, if you don't get rid of so I've had the misfortune of doing at least half a dozen redos of surgeons, including surgeons in North America, who've done a laminotomy and root clearance because they couldn't get that disc out, and these people just keep suffering. and you have to go in and chip that disc out any which way you like. Personally, I'm used to using 5 mm osteotomes and chipping it around and then taking it out in mass. But Dr. Priyank nowadays has been using the ultrasonic chisel, and he says that it's far easier to remove it with that. But I think doing a foraminotomy and decompressing the nerve root is a wrong approach.
Okay, and would you have
One
opted for
comment I
fusion
want to
in this
make, sir.
case?
Yeah, Aditya?
Can I make a comment or after Umang's?
Go ahead.
No, my only question was, would you opt for a fusion like as the previous delegate had pointed out about the facet effusion and facet
That's a completely different decision, because that would be based on his clinical profile, etc. But just going by the data, he seems to be having an auto-fusing L5S1. So this guy wouldn't fall in fusion category for me, but I think that's a completely different discussion, the fusion for this collapse.
Sir, wanted to make one comment. Can you just highlight that T2 weighted MRI picture of that case?
Sorry, I just stopped sharing. Okay.
I felt that though it was looking like superiorly migrated disc, but it's not a classical, means retrospectively it's easier to say, since now we know that it's like a hard calcified disc, but it's not a classical picture of a sagittal superiorly migrated disc, especially the rightmost sagittal cut that had something which is seen in epidural space. The blackish disc is on the lower side and hard. So whenever I see any kind of suspicious MRI picture, whether it's on sagittal or axial cut, I practice always to go to the radiologist on whom with whom I have a good rapport. I go to them, I discuss that MRI, share the clinical picture with them, and find out the possibility what it could be. So sometimes we come across even intradural discs. So whenever any suspicious MRI picture we come across, my advice is always go to the radiologist on whom you have a great faith and who are clinically very good, and discuss that MRI before going ahead and planning your surgery.
I think that's a great advice. I was just thinking how often in the lumbar spine we do that. You know, I think it's the right thing to do, but sometimes you can get wrong-footed. So I think the takeaway here is that intra-op, be prepared for a surprise. The other surprise that I've got in a disc is a facet cyst and an arachnoid cyst. Both these turn up like discs, but when you go inside, it's completely different. So if your mind does not know, your eyes don't see. The third, of course, is the double nerve root. If you'll have never experienced the double nerve root, be sure you're going to cut it. So you should be prepared to see these kind of things. Priyank?
No, so just adding to this, that tip that is always there, that so two things. One is going back to your CT scan and the MRIs that we were discussing. Whenever you're choosing a patient for surgery, don't miss out on the X-ray, because the first sign of a calcified disc you will be able to see on a lateral X-ray, where you will literally be able to see define the disc bulge. So if you see a calcified disc on an X-ray, then you want to be a little wary regarding micro procedures, because you don't have a lot of play for your osteotomes and everything. And the second part, which Abhay sir was talking about, is when don't be overconfident. Whenever you see a disc, don't rush to get into the disc space, especially using a knife. A safe way would be to use a pen field to get into the disc space rather than taking a knife, because sometimes you have a very tight, the nerve root is tightly stretched over the disc, and it becomes difficult to differentiate between the annulus and the nerve root, and especially if there's a lot of bleeding. So make sure that you take a pen field and go inside. So at least if at all there's a nerve root, you won't damage it a lot.
Perfect. And while we are waiting for more questions, I'm just putting this literature bit up where even calcified thoracic discs have got completely resolved conservatively. So there's a lot of stuff out there, and these are pictures. This is not my thought or someone else's concept. So I've seen calcified disc in the causing myelopathy go away in the cervical spine, but this is like very unique. So just because it's a calcified disc, you may not, but though we in our practice tend to leverage that for a surgery, because the chances of him or her getting better become less and less, according to me, once calcification begins. So we normally leverage that out for a surgery, but there's data out there to prove otherwise. Any other burning questions? If not, then just speak
Yes, sir.
out.
Can I ask?
Yes, of course.
What is the advantage of taking standing X-ray in lateral view, and what is the advantage of lateral view in flexion and extension?
Aditya, you want to take that?
So basically, the standing X-ray is a loading X-ray, because usually if you just write X-ray LS spine AP lateral, so that X-ray technician will do that X-ray in lying down position. So your spine is offloaded in that case. And if at all, because of the loading, if at all any instability is happening at any one of the levels, that can be missed out if we just write AP lateral view. But if your requisition for X-ray mentions flexion extension or standing X-ray, at least because of the loading of your spine, if at all any instability is also present, it can be revealed. So that's why dynamic views or standing X-rays lateral view is utmost important, so that we can get any idea about the instability, and that will help us in planning our surgery. Whether, for example, if patient is having severe back pain component also along with radiculopathy, young individual, then obviously, and instability is revealed on X-ray, then you'll err on discectomy along with fusion in that case. So that helps us in our decision making or planning of your surgery.
Also, when you're planning a longer lumbar fusion, a standing X-ray is the only X-ray will tell you about the PI and the lumbar lordosis. So if you calculate the angles, it can't be done on the lying down X-ray. So especially if you're planning a fusion, you must make a habit of asking for standing X-rays. Flexion extension, like Dr. Aditya said, covert instability can come out. And I have had too many, and I think we're going to have some later discussions in the later weeks about this, about covert signs of spinal instability, when to fuse, when there's a disc, etc.
Abhay sir,
yes.
Thank you. Abhay, sir, can you just share that MRI on the group, just the one with the calcified disc?
Yeah, I will put it, because it's on my laptop. I will put it back on the WhatsApp. But and if I don't, just send a reminder, please, on the group.
Thank you, sir. Thank you.
And
Sir?
Yes, please.
Sir, I was wondering how a disc goes into the intradural space.
Yeah, so discs that are chronic, which have been there for long, they tend to harden. When they harden, they start eroding on the dura, and the dura opens up and the disc actually then walks inside. And at least personally, I've just done that once, but one of my other colleagues, Dr. Mihir Bapat, also has that experience. So the takeaway is that if you have a huge disc, like the one I've shown you on the MRI on the screen right now, it's a huge disc occupying almost the whole canal, and you go in and you don't find it. The next thing you do is you make a laminotomy with your finger, feel the cauda equina, the thecal sac, and palpate for something hard inside, and with due precautions open the dura, and there's a very high likelihood you'll find it popping out. So I had again misfortune of repairing or doing one of these, which was missed by another surgeon, and I came in with more information, so I just went and opened it.
So sir, what happened is the disc being calcified first eroded the PLL and then eroded the dura and then entered inside.
I mean, that is one theory. The other is that it explodes so big that it gets into the dura. But there are occasions when surgeons have reported they've not found the posterior end. They create an artificial anterior end, or rather a posterior end is created artificially, but they don't find the anterior end. So we really don't know how this works. These are only theories.
But sir, there need to be a puncture in PLL, na? PLL need to be punctured to,
So PLL it routinely punctures, right? Any extruded or sequestrated disc goes through the annulus and the PLL. But going through the dura is this, exclusive right of this intradural disc. We don't pathway. The two theories are a chronic disc and the other is a big explosion that gets inside.
Okay, sir.
And one more point, sir, we can actually do a...
You just want to be aware of that possibility introp. Sorry, Harshal, go ahead.
Yeah, we can do actually introp USG also. If you don't find a disc, introp USG is also a good modality which we can tell us that intradural disc.
Yeah.
Sir, how did you repair the dura, sir? I mean, the anterior part.
So anteriorly, you just onlay. Yeah, Harshal, sorry, go ahead.
No, please carry on, sir. I mean, it's actually fibrosed. So as it has gone intradural, the theory says that it's actually already fibrosed. It's closed. You actually have to open posteriorly, to do a durotomy and do a proper repair.
Okay, thank you.
Okay, just going ahead with what we were discussing. You all can keep asking questions, but I'm just kind of getting back to the discussion we had. We talked about who would conserve this huge, huge disc with early cauda equina. And then we said that what if there was no neurology and you just had pain? And then we said, what decides? Does this size decide or does neurology decide? So if the person on the left had an EHL 4x5, would you conserve? And a few people said maybe that could be used as a decision for surgery. And then we got into this slightly messier situation where you have a disc on the MRI and you have a foot drop or an EHL of 2x5. So a significant deficit. And so far, the kind of consensus we reached was that 3x5 or something that's not compatible with your normal life, which means that if you're a running athlete, even a 4x5 may be not compatible. You would use that to leverage surgery. The big question is that will it recover with surgery? And I'd like all your inputs on this. So when you say that this guy has a 2x5 power, let's say I'm saying I want to still conserve you and you may get better. And you say, no, I want to operate. Would you then be able to give a justification or some kind of an assurance that with surgery, the deficit will go away?
Sir, it depends on the timing of the surgery, I feel.
Yeah, but let's say the week, they typically would not come on day 1. They would come at day 5 or day 6. We're there, but the pain is gone away, Shatanand. If you hear what I'm saying, this person, he's not in acute pain. So there's one where there's an acute pain and a foot weakness. But here the pain came and went away on day 4. And he's come left with this weakness.
So recovery can't guarantee, but yeah, any method for that matter, recovery can't guarantee. But if you leave it like that, it can progress. So progression, if he's for older people, okay, but young athlete and all, it's better we get it back to the normal anatomy is what I feel.
But old is how old? I'm 50. But I just ran a 10K this evening.
No, old means depending on the activity. Old
No, I'm just pulling your leg. I'm saying that these are unanswered questions. And if any one of you has any thought process on the questions that I've put up. So, because your patient is asking you this and they're asking me this every day. If you do surgery, what are the chances that I will recover? If you conserve, what are the chances I will not recover? And by delaying, supposing I take 2 more weeks to think about this. And if I'm not better, I do a surgery. What are the percentages that I will not recover with surgery? Dr. Bhatt, do you want to say something? Anyone wants to say, please jump in.
Usually in the clinical practice, when there is a neurological involvement, I would definitely go in and take out the disc if there is a definite exclusion or something. If there is no neurological involvement, if just the pain, I think we can still manage conservatively. The patient does not want a surgery, sir.
Right.
Somehow, sir, by convention, I have actually made a thought process that if there's a painless neurology, then I think it's a settled neurology or it may be improving neurology. So I would not intervene. But if it is a painful neurology, I would want to intervene depending upon the duration and all.
I think the result of conservative versus surgical in patients with a painless deficit is the same. It's basically then the neuropraxia, and it completely depends. Like the recovery pattern is going to be the same. I don't have a experience but I have with experience found that people with painless deltoid deficit. Now I've got 4 patients in the series with painless deltoid deficit 1/5, 0/5 have completely recovered. But that's specifically which I've collected for the cervical deficits.
Right.
Sir, I have a small question. Does this neurologic recovery is equivalent to what we have in a peripheral nerve, or does it act a bit differently?
It should be exactly the same. The neurological recovery should follow exactly the same pattern. But what we are trying to say is that like in practice, this is what I find. Whatever literature I've searched, this is what I find, that if someone has a deficit and no pain, I would counsel him saying that if you do surgery, there's a 6 or 7 out of 10 chance that you'll recover. If you don't do surgery, there's 3 or 4 out of 10 chance that you'll recover. Which means that by doing surgery, it's not 100% recovery. If you don't do surgery, it's not a 0% lack of recovery. So this is like the in-between boat that I would counsel them. Because there are tons of people with deficit who we've operated in time who have not recovered. And there are tons, which I'm going to show you finally, But quickly, I want to just show you this, that who would you conserve, and that this has been our unit philosophy. Someone with lesser pain, shorter history, means not recurring history, but a shorter history, longer duration of deficit, minimum deficit, soft disc, no instability, no bony stenosis, and a patient profile who's desperately not wanting a surgery would end to conserve. While the other, on the top, someone with a longer, shorter deficit that's urgently happened, someone who has a deeper deficit, someone who has more recurring symptoms, a hard disc, instability or bony stenosis, and a urgent kind of a patient profile, or a high demand spine, as we say, you would get to operate. This is just philosophy. Anyone wants to butt in here?
Sir, I think it depends more on the cause of the prolapse. Like if a weightlifter lifted weight, he got, and if you,
Satanand, you're breaking up. Can you say that again?
sir, I think it depends on the cause of the disc prolapse. So if it's because of sudden, like a weightlifter has lifted weight and its disc has prolapsed, and he is getting deficit, then the more immediate we do, he'll recover better, sir.
So there's no data to suggest that, I mean, I'd love to believe that very oversimplified answer, but just like a fracture, a fracture spine, this seems to follow the same, same pattern.
Abhay, sir?
Yes.
Umang here. Hello.
Yes.
So, sir, with regards to the question that you've just asked, there was a paper recently, I think last year, by a group from Austria, where they had which was published in Spine, where they spoke on motor recovery post discectomy surgery. So, according to the group, they've said that in cases where you have a deficit which is less than so probably the power is less than 3/5. In such cases, if you are going to delay surgery, or you are they found that the recovery patterns were not great. Like, I mean, a delayed surgery with in a case of profound deficit was detrimental, in fact, to recovery. And these patients, in fact, if they found that if they were operated within 3 days, they did find a better recovery. Like, so they had classified patients into, based on the power MRC grading, based on the power and when they were operated. So probably a patient which had a power which was 4/5 and was probably operated after 3 days, was not affected as much as what a person with a power less than 3/5 or 2/5, and then operated after 3 days. So the recovery patterns they had compared, and according to them,
Umang, you could put this on the group, because I'd be interested in reading this for sure. What I deeply suspect knows that their randomization may not be adequate. I mean, they may not have compared the right groups, but I'm being presumptive. So I'd like to read this and try to criticize the the paper, and then we can have that open discussion on the group.
Yeah, sure, sir. I'll put
it.
And it may find the
sorry.
Yeah, you may find it anecdotal, but I would just like to butt in here. Dr. Nene, correct me if I'm wrong. I have found that even if it is a EHL or a T-band weakness, which is 3- or 2+/5, and patient is not willing, and we conserve him for some time, we have found that patient has recovered wonderfully well, many more often than not. And this happened more with the upper cervical disc. So deltoids, which Dr. Priyank recently told, we have had n number of patients who had weak deltoids, and we're like, yeah, chalo, it's a surgical case, but somehow at 2 weeks or 3 weeks down the line, they have recovered completely. So though it's anecdotal, we have not published it, but that's been our experience.
So as you can see, we're scratching on situations. Yes, Shadan.
Sir, I saw a slide where I've written conserved it, and it has the pre and post this thing. Sir, what exactly conservative treatment have you given us, sir?
So nothing, just time and reassurance and vigilance. I mean, in terms of conservative treatment for a person with a deficit, the first demand is the few boxes that person should tick is that one is he or she should be fully motivated for non-surgical treatment. He or she should be educated, willing to share the responsibility or the burden, and being available for regular follow-up. So we have this, pretty high-end South Bombay practice, and people are of that nature. They're willing to come in every week to have a recheck. We don't have time, but our physical therapists manage. So vigilance and time and activity modification is the only conservative treatment, literally.
Okay.
And
Physiotherapy or traction or anything?
By the way, this is in reality. And I am not advising that you should try and conserve chordae equinas because it's too risky. Maybe you should get a signed out agreement with the patient if you're trying it. But I have done it more than once, and I think I have the bandwidth to absorb this situation. But I'm not giving this out as a message.
Sir, I had a patient 2 months back with similar kind of disc. I might share you next time, sir.
Yeah.
And he had been having this disc problem, the same chordae equina, such a big, large base disc extrusion. And he was roaming around with this for around 3 years. I advised him surgery 2 months back because he came to my OP 2 months back, and I saw this and told him you will have to undergo a surgery. 2 months later, he landed up in the emergency with the bowel and bladder involvement. And since 1 month post surgery, still he's not recovered, sir.
Yeah. We recently
Without
had
any
that
motor
situation
weakness,
with,
sir.
yeah, we recently had that situation with the lumbar stenotic who we had conserved, who came with a bladder and bowel, and these can be very disturbing, which is why, I mean, this is completely legit and this can happen. And then, you feel lousy, the patient feels lousy. So you have to have a motivated patient who's willing to take the responsibility of these situations. And only then you should consider, putting them through non-surgical treatment.
Sir, one question.
Yeah.
Sir, why can't we be aggressive and we take out the disc? Because now facilities are available. Microdiscectomy doesn't do much harm. Endoscopic also doesn't do much harm. So we are actually not putting the patient through a lot of stress. So isn't it safer to intervene earlier than it will cause be more aggressive than go to conservative?
I think 100% I agree with you. And even this patient who I conserved, I told her you should have a surgery. Okay, so my side of the table still said you should have a surgery, but it is her who said, I don't want, can you do something? So I put all the facts across because, like I said, well-read and educated. And then we embarked on a non-surgical treatment. And no one who has this kind of a deep deficit goes away from the clinic being told that, no, you'll be fine without surgery. So 100% you want to hard sell surgery to them, and only in a special circumstance you don't do it. So I think that's 100% true. Just before we close, does anyone have any thoughts on these kind of situations? Multi-level extruded discs. Do you all have any tips or tricks to localize which one is a symptom causing disc? If you were to operate this patient, how would you
We can
diagnostic
use
blocks just before the surgery.
blocks, sir.
But in reality, I think it's a myth, because if this lady comes with, radiculopathy and, miserable while walking, are you going to tell her that today I'm going to inject this disc here, tomorrow? So let's take this MRI, that one day I'll inject this disc, then after 48.
Diagnostic blocks just before the surgery.
Clinically assess and then plan for the diagnostic block, sir. Clinical assess where exactly what disc, and the axle will give a better idea, sir.
Yeah. So in her case, the pain was corresponding to this disc. Yes. It was purely left-sided, below the calf kind of radiculopathy. No
so
deficit.
That we can't make out, sir. Your screen is getting blocked with this one.
Oh, I'm sorry. How do I? Okay. Now can you see?
Yes, sir. Perfect. This is the
huge chunk of disc sitting on the left recess, and she had huge radiculopathy down the left S1. Okay, there is an extrusion here, as you can see. There's an extrusion up here. Some of the cuts have been missed, but this also is an extruded fragment. I don't know if you can see it. This is an extruded fragment. Yeah. So, I mean, in my practice,
would you
just to take
then
care
would you counsel them that you'd continue? Would you tell them before surgery that, ma'am, you'd continue having back pain in spite of the surgery because you have discs at several other levels?
Actually, that I would tell them, even if they, had a one-level disc. Sorry, some other images come up here. Even if they had a one-level disc, I would counsel them that the surgery is not going to take care of your back pain. It's only going to take care of your leg pain.
And impending cauda.
I mean, yeah, if you thought there was cauda, sorry, I've just missed this image somewhere. But we were just talking of a multi-level disc, and just because it's a multi-level disc, I'm not going to say back pain won't go. I'm going to say that regardless. In this particular patient, I just offered to go after this one and leave these for their own fate. I don't know how you guys look at it. I did not offer selective root blocks as a lead up to the surgery because clinically this matched. And I said, you have bad discs, but there's a huge difference between doing a one-level microdiscectomy versus doing a 5-level interlaminar approach for for your symptoms. So I'm not in the in the business of doing preemptive surgery for discs. I also told her that we see a number of people with extruded discs or bulging discs who have no symptoms. So it just because this is there, it does not mean that's the culprit. At the same time, if you wish, we can go after all the discs, but that, that's a much bigger operation which you don't need. But I was just trying to ask you guys if you have a better solution, because I don't, and this is how we go about it.
Similar, sir.
Yeah. So this is great. Then it's been fine. And Harshal, you
no, Priyank sir was saying something, but I don't know. He's not.
I was
Your
just
voice is not.
Yeah, sorry, it was on mute. So I was just telling about such type of patients, decision making. So like what Abhay sir said, one level microdisc ideal if the patient has that single leg radiculopathy, but somewhere in the decision making process, even the patient personality.
Again muted, sir.
Priyank, you're muting.
Yeah, so if it's an educated person who understands that we are doing a micro procedure with a real reality that later on we might have to do one more procedure, but then this procedure is a smaller procedure, it works well. But let's say if you have a patient who who does not have access to hospitals, who's low socioeconomic strata, does not understand well, it's better then to radiologically address both the levels, so that at least radiologically you're clear and they don't have to get back again and again. So somewhere that patient personality and your counseling also helps. So in such a patient where I have to operate, I have started doing a spinous process approach and tackling that like a primary LCS, and then just doing discectomy where the roots are getting tucked.
Lovely.
Yeah. So there's one case scenario I want to just ask. So right now I'm having a patient with a right-sided large extruded disc at L5S1, and patient is having left-sided radicular symptoms. There's nothing in the lumbar spine with any left-sided nerve compression. There's a thoracic OLF which is on the left side, but my patient is having only radicular symptoms. So how would you take that up?
Like if you're asking me, I've had success in operating them if they're surgical. Yes. Like the surgical patient, even if the disc is contralateral, I am going to think of it like a counter coup mechanism. Take the disc out and they get better. But he should be surgical. If he's not surgical, your problem is solved.
Yeah. The only thing, Harshal, probably what I would do here is instead of doing a classical micro disc, I would do an interlaminar disc. And of course, after removing the disc, check the root which is actually symptomatic, the opposite side root, just to see if we have not missed out anything. Because you can sometimes have a big disc on the right side and a small extruded fragment which has gone and sat across the left-sided nerve root, and that you miss out and the patient was significant.
So I called for the CD of the MRI. I went across, I put it on my computer, but there's no extruded disc anywhere to be found. But I also agree that the root appears to be tented over the facet. And for me, it's like the counter coup type of a scenario. Yeah.
And it's actually published in literature that there are counter coup type of injuries who do really well by addressing the pathology on the MRI.
Sir, in this counter coup disc, which left or right would you approach, or the symptomatic side?
No, you do an interlaminar approach. Take the disc fragment out and explore the root on the symptomatic opposite symptomatic side.
Any counter coup foot drops you have seen? 2 weeks back, I had a patient with extruded disc on one side and foot drop at the other side.
Yeah, but you would still want to address it, because I've had people who, after doing a unilateral microdiscectomy, have developed a foot drop on the other side post-op. So, shit happens basically, and we are just at the.
Sir, when it comes to the resorption of a disc, sir, is the large disc after resorption the only mechanism is calcification to get resorbed, or it's like वो बिल्कुल normally हो जाता है?
Normally 80%, 70 to 80% of discs get resorbed and cleaned, and we've got tons of MRI to show that. Maybe Aditya, we can put up on the group in the coming week when we are especially discussing today's discussion. But a few of them that don't resorb tend to calcify. So that's one of the reasons why we do these asymptomatic MRIs on an annual basis in people who've had conservative treatment with a big disc, because if it's not going away, the longer it's going to stay there, it's going to start getting calcified.
But sir, I've just put up on
it sounds like a wonder.
Disc.
Yes.
Sir, does the age have any role in the decision making? Age of the patient.
Decision of?
Sir, does the age play any role in decision making? Age of the patient.
decision regarding surgery or no surgery?
Yes, sir. Yes,
So
sir. Yes, sir.
the only
And
in my
what type of
again,
surgery?
So the only in teenagers, that's 13 and 14-year-olds with a disc prolapse, the success of conservative treatment is very, very, very low. Most kids who are like pre-teenage, who have a disc prolapse, they have the sticky disc with an end dislocation, and they typically don't get better and need to do surgery. And typically, when you do the surgery, the whole disc comes out. Normally, counsel them. After that, it has got nothing to do with it. Once you're a fully grown adult, it's only your demands and your lifestyle that will play a role in the decision making of your surgery.
One quick bite of
Dr. Mohan, can you mute yourself? Dr. Mohan, can you mute yourself? Mohan Kumar.
Ortho TV will be able to do it. Ortho TV should do it.
Sir, in
Can
case
you
of
give your
old
two
age,
bits on endoscopy?
Endoscopic
Discectomy.
discectomy.
Yes,
It's
sir.
a new procedure which is, I think, here to stay, and it has got lots of credible people who have been doing it, and I've seen people do it. And I think in my practice, we would ask a patient to consider an endodiscectomy if it's a far lateral disc, where my approach would be much bigger because I would go through a Wiltse approach. And otherwise, if it's a corner disc, in the just outside the foramen, maybe. But I have not had any downsides of microdiscectomy, which is why I'm not moving to endoscopic discectomy. But I think people who are trained in it should very well do it. Patients who have had microdiscectomy, at least in my experience, have gone back to international football, cricket, marathon running, mountaineering, and they go home the evening or the next day of the surgery. So I don't see a particular benefit in the endoscopic approach. If
My
the patient
question was
asks
just
for it,
to
yeah.
ask whether I should invest time and money in endoscopy training and
It totally
equipment.
depends on your practice, the region that you're practicing, because today I must say that I'm one of the more senior surgeons in our city. So people would say, you operate, do what you want. But if you're competing with a group of 20 other surgeons and you need to rest the patient, you may want to offer something that's more contemporary, because you may lose your patients because of that. So this is a completely non-scientific advice. It's just a social and a practice-based advice.
Thank you, sir. Thank you.
Sir,
So
last question. Sir, he mentioned about endoscopy. Sir, do you think like the back pain will be less in endoscopy compared to microdiscectomy, or it will be the same?
At least so far, that has been proven that MIS does not reduce any MIS. And there are just, offhand MRIs that are being shown where less muscle damage has happened. And I think the capacity to reduce back pain totally depends on the patient's capacity to do rehabilitation. When you see people who've had, so I can't name them, but there are famous international people who've had these fusions by us, not even by some celebrity doctor, who have gone back to all activities which you can't even imagine, and with no back pain. At the same time, there are people with faltu microdiscectomies who howl with pain for the next 5 years in your clinic. The same surgeon.
Yes, the mostly patient dependent.
Yeah, exactly. So don't fall for that. But if you're selling your endoscopy, of course, you can tell the patient that. Chota scar, come pain, why not?
Yes. Thank you, sir.
So is that good now? We're like 10:30 and no one's had dinner. We're 10:40.
So it's nearing 11.
Sir, I
Yeah,
have two
it's almost
questions. Sir.
11.
Sir, I have two questions, Dr. Nene.
Nitin, and then maybe Aditya, you can help winding up.
So the question number one is, sir, I was wondering when this annulus fibrosis has undergone some deformation and this indistortable substance comes out, when resorption occurs, everything repairs itself.
No,
sounds
it doesn't repair.
Wonderful.
The annulus can repair it. No. The annulus remains open, but the extruded fragment dissolves. Even after surgery, the annulus remains open. So someone was asking on the chat box, how much annulus do you cut? You don't cut the annulus. You just go through the natural opening, because the more you cut, the less you're going to let it, get better. It's never going to get better.
Okay. And so when it comes to, as it was said, that when it's a large disc, it is more liable to undergo a resorption. So is it more of a fallacy? A larger things looks to reduce.
It's the surface area. Nitin, it's the surface area, because phagocytosis happens around the surface area. So bigger surface area, more phagocytosis.
Got it, sir.
Again, almost proven.
Yeah, and so the last thing is about the disc arthroplasty. So, any word on that, sir?
So lumbar disc arthroplasty largely has died a natural death. There are some centers, Harshal has visited a few, which are aggressively still doing it and selling it, but at present it has no proven benefit 15 years after it came up, and the complication rate and the rate of redo surgeries can be very devastating, as against a cervical arthroplasty, which once it's done, it becomes a fusion. So the simple answer from us would be, don't venture into lumbar disc arthroplasty.
Thank you, sir. Thank you, sir.
Aditya, would you like to close the session and then tell us about the next?
Sir. Yes, sir. So first of all, great first session of our virtual online fellowship program. I would like to thank Ortho TV to start this initiative with VR Spine Group. I would like to thank Dr. Abhay Nene, who is our senior most panelist over here, for taking out his valuable time. Thanks Dr. Harshal, Dr. Priyank Patel for their inputs, and for the most important, all delegates who are enrolled with our program, for taking out their time as well, for their interactive enthusiasm was amazing throughout all 2.5 hours what we are having this extensive discussion about PID. So we'll take things forward in next week on topic of lumbar canal stenosis or degenerative lumbar disease. So the exact session, when will that happen? We'll give you idea at least 2 to 3 days prior. It will be either on Thursday or Friday. So well in advance, 2-3 days prior, we'll give you idea on the group. And as we told you earlier also, whatever your questions about the topic discussed earlier or whatever topics is proposed next week, you are free to ask any question anytime in that group. So we are ready to take those questions and we can help you to answer those questions. So thanks a lot again, and we'll sign it off for today. Thank you, everyone.
Thank you, Dr. Abhay and team.
Dr. Ashok, you want to say something? Yeah.
Just want to thank you all. It was an excellent session. I learned a lot of things, a lot of practical tips. Absolutely treasure session. Thanks. Good night.
Thank you, Dr. Ashok.
Good night, everyone. Good night.
Good night, everyone. Thank you.
Bye. Bye.
Maharishi, you can end the session.